Good day, ladies and gentlemen, and welcome to today's Vetfolio presentation as we explore a case-based presentation on treatments for superficial staph skin infections in dogs. My name is Matthew Lyon, and I'll be serving as your host and moderator on today's session. I'd like to thank our event sponsor, Zoetis, who's helped make this presentation available, and to those of you joining us from around the world, we welcome you to the broadcast. It's my great pleasure to introduce our keynote presenter today, Dr. Andrew Hillier. He is a Senior Veterinary Specialist with Zoetis. Dr. Hillier, we'd like to go ahead and turn the presentation over to you at this time.
Thank you, Matthew. And I guess it's good morning, good afternoon, or good evening to you, wherever you may be. I know we have people from around the world. And thank you for joining me on this webinar, and I feel honored to be speaking with you. I'm going to actually be using 6 or 7 dogs with superficial pyoderma to illustrate what I believe are important elements in the diagnosis and treatment of this disease. And the important things that will come through as we discuss each of these cases is when to perform cytology, when to perform a bacterial culture, what topical therapy is best, does the patient need systemic antibiotics, and what systemic antibiotics should you use? So we're going to start off here with Moose, who is a 3-year-old bearded collie. And Moose has a history of several bouts of pyoderma over the last couple of years, and they occur about every 4 to 5 months. The dog has moderate pruritus when the infection, or the rash as the owner sees it, when that infection is present, the pruritus is moderate. Otherwise, once it's resolved, then the pruritus is actually mild, and it doesn't seem to bother the dog too much and doesn't bother the owner terribly either. In the past, when he's had these infections, he's been treated with 3-week courses of cephalexin, and he's also on occasion had an injection of dexamethasone to start that treatment to reduce the immediate pruritus. So in physical examination, what's affected in Moose is his trunk, as you can see here, and the proximal limbs. Actually, let me just get this. I want to get my pointer. So it's the truncal area, which we can see the ventral part of his trunk here, and the proximal limbs. And the lesions that are present are mild to moderate erythematous papules. So as we take a closer look at the lesions in his groin area, you'll notice here that there are multiple papules, and in fact there's even a little pustule here, and you might notice that there's a little bit of a collarette just over here, and maybe a little crusting over here. These are the lesions that if you look through his coat throughout the trunk, you'll find that they're present in all places throughout the trunk. In addition to that, on careful examination, there are actually some pustules. So this dog was treated with cephalexin at 22 milligrams per kilogram every 12 hours for 3 weeks, as well as we dispensed chlorhexidine shampoo to be used once every 2 weeks. And in fact, we just said to the owner, you can use it if possible, and she said she's likely to go to a groomer because it was challenging for her to bathe this large dog with this long coat, and especially as this was when I was living in Ohio and it was winter, it was going to be very difficult to dry the dog off. So it's just, can you use the shampoo maybe every 2 weeks? And if not, then you can get your groomer to use the shampoo on the dog. So I want to make some comments after each case, and we'll go through some of the aspects of the individual case. So for Moose, the first comment I want to make is there was a lot of confidence in the diagnosis. He had absolutely typical lesions. There were pustules, there were papules, there were collarettes. He's had these in the past. He's had a history of treatment with cephalexin, and he's totally responded, and the rash and the infection has gone away. So the level of confidence about the diagnosis was really high. Why did we dispense cephalexin for treatment in this dog? Well, the owner shared with us that she was very happy to give him oral medications. And in fact, if we wanted her to give him oral medications for 3 months, she could do that. And the reason being, he ate the capsules out of her hand. And that was because he always got a treat after he'd been given the capsules. So it was very easy for her. And then why did we only bathe the dog every 2 weeks? Because I'm sure that you've heard of whenever you use chlorhexidine shampoo or you're using some kind of antimicrobial shampoo, you probably should do it twice a week if at all possible. And that's true. I've said that many times myself. But this was a big dog who lived indoors, who was going to be difficult to dry off. And, and it was winter, as I said. So instead of putting pressure on the owner to do something that they probably couldn't manage, I said, if you could just bathe this dog once in the next few weeks, that's going to be terrific. So the question really is, how many dogs are like Moose, where the dog loves taking medications out of the owner's hands, and where the owner can be utterly relied on to complete a full course of oral antimicrobials like cephalexin? Of course, there's very few like that. And non-compliance is a huge problem in veterinary medicine. So we had 3 studies, and the results of these 3 studies showed that less than 55% of dog owners, and in fact, in 2 of the studies, only 27% of dog owners administered the correct number of antibiotic doses. This is a good reflection of the poor compliance that we see with medium to long-term antibiotic therapy. And can you tell who will be non-compliant? Unfortunately, the answer is no. Studies in both humans and veterinary medicine prove that it is impossible to predict who will be non-compliant. And in this study by Barter et al., 71% of the dog owners self-declared to have been fully compliant, and yet only 10% of them returned the correct number of pills. So the fact is that it's very difficult to know who's going to be compliant with a course of oral antimicrobials and who isn't. And the guess is going to be that the vast majority of people are not going to be compliant. So let's look at our second case. This is Bruiser. He's a 20-month-old pit bull cross. And he has a pretty short history of skin disease. In fact, this is only the second time he's been seen for skin disease. His last visit was about 5 weeks ago. And at that time, he had a negative deep skin scraping, so he does not have dermatosis. And he doesn't have a history of much pruritus. He has minimal to very mild pruritus. Previously, 5 weeks ago, the dog was treated with cephalexin at 500 milligrams twice daily, and 28 capsules were dispensed, in other words, 2 weeks' worth of treatment. And the owner reported that the dog was better. The lesions and the rash that they saw seemed to improve. I'm not quite sure if it totally resolved or not, but it definitely improved to some extent. On physical examination, you'll see over here that the ventral trunk and the groin area, as well as the axilla, were both severely affected. And in fact, if you look closely, as we can see on the right-hand side here, you'll see multiple papules, as well as some pustules. There's a pustule here and possibly a pustule over here. And these are the type of lesions that we saw throughout the ventral trunk. Bruiser's treatment was convenient at the label dose of 8 milligrams per kilogram, single injections given subcutaneously. And then we also dispensed chlorhexidine shampoo, in this instance, to be applied once weekly. It's a short-coated breed, the owner said. Shouldn't be too difficult to bathe the dog, not difficult to dry him off, so once a week was a reasonable expectation. So what are the comments about Bruiser? Well, what about compliance with oral antibiotics? There's a problem for Bruiser. He's a boisterous dog. And quickly, after 3 or 4 days' worth of medicating him with oral antimicrobials, he knew when pulling time was coming. It became a major challenge for the owner. And of course, if we have poor compliance, we expect that there's probable failure to resolve infection. These owners would do their best to administer the capsules twice daily, but it really became very difficult for them. And then they would get fewer and fewer doses, they'd miss doses, and then they'd stop giving the antibiotics long before they completed that 14-day course of antibiotics, which had previously been dispensed 5 weeks ago. And to be honest, I'm not sure, but I strongly suspect that the infection previously 5 weeks ago never really resolved because the owners didn't complete the course of antibiotics. And what we were seeing now, 5 weeks later, was not a new infection, but really just a flare of the original infection that we'd failed to resolve. So of course with Convenia, there's no missed doses. Single injection, no one has to be adherent compliant to any instructions. It doesn't matter how boisterous Bruiser is, we're not going to have any missed doses. Not only that, as he improves, we're going to continue to have therapeutic levels of sulfobacin in the skin to treat this and kill the bacteria. And so there's no premature discontinuation of treatment as the skin starts to look better, which is frequently the case with owners who are treating their dogs with oral antibiotics for skin infections. The other thing about convenia is that we're above the MIC 90 of Staph pseudointermediates consistently for up to 19 days in the skin. And basically what you're looking at here is a dose-response curve. When you give an injection of convenia, of course, the concentration goes up to a Cmax very quickly, and then it's slowly eliminated from the body. And this is kind of what we see after 14 days in the serum. We actually have some really good information that tells us that in the skin, tissue cage studies have shown us that in the transudate, the levels of convenia in the skin are still at therapeutic levels that will kill Staph pseudointermediates up to 19 days after administration. That's really helpful to us in resolving infections. The owner did actually report that they saw rapid improvement in the dog's skin. And this is not surprising. Here you see a picture of the dog beforehand, and this is what we saw on day 14 at a recheck. Total resolution of the skin infection. And this is because we're not relying on the owner to continue to administer medications either twice daily or once daily. We have convenia levels or sulfobacin levels at therapeutic concentrations in the skin every minute of every day for 14 days, in fact in the skin as long as 19 days. So there's no missed doses which can allow bacteria to survive and escape. That's why we tend to see really rapid and quick resolution of lesions. Okay, here's the third case. This is Scout. He's a 5-year-old English bulldog. And Scout has a long history of skin fold infections, in which dog brachycephalic, for example, that has all these skin folds in the face, and the neck, and the chin, doesn't have skin fold infections. Most of them do. And he's had these since he was 6 months of age. However, there have been increasingly common infections that are affecting the trunk and the neck, not so much skin fold areas. The owner reports that there's pruritus in the affected areas around the face, the neck, and the trunk, and the feet. It's about a 6 out of 10 on the pruritus scale. And since these infections of the trunk and neck have been noticed, he's been treated with numerous courses of cephalexin, dispensed at 750 milligrams twice daily for periods of 2 to 4 weeks. The owner reports that the lesions definitely improve on the trunk and the neck, but the pruritus seems unchanged whether he's on antibiotics or he's off antibiotics. So on physical examination, what do we see? Well, the chin and the facial folds, here we have the chin and the facial folds, you see this erythema and then the exudation accumulation, typical of what we see in dogs with these intertriginous or fold infections. As well, on the neck and on the trunk, we have these multifocal areas of alopecia, and there is some crusting, as we can see here, and underneath those crusts we could see some papules. So the diagnostics performed on this dog, there were deep skin scrapings, and they were negative. We want to do that with multifocal areas of alopecia. We also performed cytology. What we saw under the crusted papules on the trunk was 2+ coccoid organisms, and you can see here diplococci. There are quite a few of them. You can also see some nuclear streaming, which is just the nuclear material from the neutrophils that are in the area and responding to the infection. Cytology from the facial folds showed mixed bacterial infection, and you'll see there's some coccoid organisms there. In fact, I've just covered up some rods. There's a rod there, and even a couple of yeast as well. So there's kind of a mixed bacterial and yeast infection in the fold areas. And a straight coccoid infection here from the papular areas on the trunk. Scout's treatment was Simplicef, or cefpodoxime proxetol, administered at 200 milligrams once daily. We also dispensed a chlorhexidine shampoo to be used twice weekly in this instance. And then he had a third treatment, which was a chlorhexidine clombazole wipes. These wipes from the company Duxo have clombazole and 3% chlorhexidine. And we asked the owner to use these wipes in the fold areas around the facial folds, the chin, and the interdigital areas every second day. So let me make some comments about this treatment and scout situation. Why Simplacet for him? Well, if you ask this owner, share with me your experience of when you previously administered cephalexin to him, what she would say was that it is really difficult to get 2 capsules twice a day into him because he's a bulldog. He has a lot of saliva. As soon as he opened the mouth, the saliva went onto the capsules. They became sticky and soft, and they'd break up. It was kind of difficult to get them down to the back of his tongue. Not only that was it somewhat difficult to get capsules in, but it was also twice a day medication, and it was multiples of the medication. So when you give cephalexin, this dog was going to get 4 capsules in total daily, whereas if we went with Simplacet, it was only once a day, which was far better for her to only have to administer tablets once a day. And then she only had 1 tablet, which was much easier to put down his throat than actually 2 capsules. So that is advantageous for her, even though she could struggle through cephalexin if absolutely necessary. Probably the most important reason why I wanted to use Simplacet in this dog is because the pharmacokinetic profile of Simplacet is the best of all the oral antibiotics that we use to treat staph infections. Now remember that the beta-lactams, and so far we've spoken about cephalexin, we've spoken about Convenia, and now we're talking about Simplacet or cefpodoxime. And all of these beta-lactams are time-dependent antibiotics. And their efficacy is directly and strongly associated with the amount of time that they are above the MIC of the organism that you're trying to treat. So in this dose-response curve that we're looking at here, you'll see here on the y-axis we have the concentration of Simplacet. On the x-axis is time, and it goes out to 25 to 30 hours. This line over here is the MIC90 of staph pseudo intermediate. So for time-dependent antibiotics, we want to be above the MIC90 for as long as possible during the dosing interval. And what I want to demonstrate to you here is that even at the low end of the dosing range with Simplacet, which is 5 mg per kg, as you can see with this dark blue line, we're above the MIC90 of staph pseudo intermediates. Remember, that's this line over here. We have a concentration of Simplacet above the MIC90 for around about 21 to 22 hours, about 90% of the dosing interval. When you actually administer it at the high end of the dosing range, as you can see with this yellow arrow here, which is 10 mg per kg, the high end of the dosing range, you're above the MIC90 of staph pseudo intermediates for at least 24 hours, so the entire dosing interval. So this is what I mean by the fact that Simplacet has a terrific pharmacokinetic profile for the treatment of staph pseudo intermediate skin infections. We're above the MIC90 for 90 to 100% of the dosing interval. That's not the case with cephalexin, where we might only be above the MIC90 of staph for as little as 40% of the time in some instances. So this is really advantageous for potential resolution of infection when we use Simplacet. I wanted to comment also with Scout that we use topical wipes. So for me, even if I'm using a systemic antibiotic, and that was the case with him because he had superficial pyoderma, the crusted papules and the multifocal alopecia areas on his trunk and neck. So we were going to use a systemic antibiotic like Simplacet. But he still had surface infection. And whenever you have these surface infections, either in the facial folds of the chin or interdigitally, I really like to use wipes. And the advantages of wipes is that they clean the area and dry the area. That makes that environment unfavorable for the overgrowth of the bacteria and yeast that tend to be found there. And secondly, you're applying the topical antiseptic, chlorhexidine or miconazole, whatever it is, you're applying that directly to the bacterial or yeast agents that are there. So there are a number of reasons why wipes are really terrific to use when we have surface infections, even when we still got systemic antibiotics on board for a superficial infection. And you will have noticed now that I've talked about chlorhexidine shampoo in all 3 cases. So why do I talk so much about chlorhexidine? There are a variety of other antiseptics that we can apply topically. So in 2012 in the journal Veterinary Dermatology, there was a review of topical therapy for skin infections with bacteria and yeast. And in this review, they assessed all the data on studies that have been done looking at all of the antiseptics used for topical treatment of these skin infections. And looking at both in vitro and in vivo clinical studies, there was good evidence for the efficacy of chlorhexidine in bacterial skin infections. And in fact, there was better evidence for chlorhexidine than for any other topical antiseptic. So for me, unless there's a specific contraindication for chlorhexidine, which is rarely the case, I will always use chlorhexidine because it gives me the best chance to aid in the resolution of the infection, because that's what numerous and multiple in vitro and in vivo studies have shown us. Okay, our next case is Sasha. Sasha is a 3.5-year-old female Shar-Pei. And she has a waxing and waning history of patchy alopecia for about the last 1.5 years. The previous veterinarian looked at this dog and thought that the lesions looked terribly like ringworm or dermatophytosis. And they'd actually performed multiple DTM or dermatophyte test medium cultures, and they'd got some fungal growth. They were positive. So there was fungal growth on the media, but unfortunately they didn't go the extra step and actually do microscopic identification of the macroconidia to confirm that that fungal growth was actually dermatophyte fungal organisms and not just a contaminant. The dog had been treated with several topical and systemic antifungals, and there had been very little improvement, although there had been some waxing and waning of the alopecia, but it didn't seem like the antifungals specifically led to significant improvement at any time. And there was also a history, the owner informed us, of some use of cephalexin and cefpodoxime, although they indicated that the duration of treatment was pretty short, and they really didn't have any idea of what the dose was. So that history was kind of sketchy. So what did Sasha look like? Well, looking at the trunk and looking at the limbs, so on the trunk here, and on Sasha's limbs, we see these multifocal areas of hair loss. Okay, and you can see many patches of hair loss. And this is what we call that moth-eaten appearance, okay? And when you look really closely at these, you'd find that there were no papules, there certainly were no pustules, there were no crusts, and these dogs tend to have hyperpigmented skin, and you couldn't see erythema. So the only thing that was visible was this moth-eaten multifocal areas of alopecia. And then I totally agree with the previous veterinarians. We had to have some concern for the possibility of dermatophytosis. We also were concerned about the possibility of dermaticosis. So these skin scrapings were performed and they were negative. Before we did another fungal culture, we did some cytology from these areas of alopecia. And this is what was seen. There were quite large numbers of diplococci, and you can see them adherent to these keratinocytes. And this is a keratinocyte, and this is another keratinocyte. And you see these diplococci here adherent to the keratinocytes. Notice that there are absolutely no inflammatory cells. And for me, that's quite typical of these dogs that have just this moth-eaten alopecic appearance, where they don't have crusts, they don't have pustules. You may not see any inflammatory cells. And don't be put off by the absence of inflammatory cells. For me, looking at this cytology, this is still very strong evidence for and proof that this dog actually has a staphylococcal skin infection. So the moth-eaten appearance, absence of the typical lesions, do cytology, and you'll see that there's large numbers of coccoid organisms. What did we treat Sasha with? She received clindamycin at 10 mg per kg twice daily for 2 weeks, and then asked for a recheck. Same time, we wanted to bathe her, but this owner told us the dog hated water. There was no way that she was going to ever attempt to bathe this dog. And even though it had a short coat and doing topicals was a great thing to possibly try in this dog, this just wasn't going to happen. So we didn't want to put the onus on the owner by giving them some kind of shampoo and make them feel bad that they couldn't do it and struggling with that. It wasn't worth that. So we just stuck with the clindamycin. So some comments on Sasha, this case. And the question here is about cytology. When is it important to do cytology? We've done it in a couple of the cases so far, but not on all of them. So for me, if typical lesions like pustules or crusts or collarettes are not present, And if you have any doubt about the clinical diagnosis of the staph infection, that's when you should do cytology. So if you examine a dog and you say, I see pustules, I see papules, I see crusts. Remember Moose, that first case that we saw, the bearded collie, where we saw pustules when we looked in the hair? And that dog had a great history of responding to antibiotics. That dog didn't need cytology, in my opinion. We were very confident about the diagnosis. Go ahead and treat the pyoderma. But if you question yourself and you are not anything but 100% confident, in other words, you say, I'm just not sure whether this dog has pyoderma, that's when you should do cytology. As we might have thought here with Sasha, with this multifocal moth-eaten appearance, and there were no pustules and no crusts. Or maybe this dog here underneath, where we have these crusted papules arranged in rather unusual patterns. And you can see here the pattern, that's a circular pattern of arrangement, and even this here, which is kind of like snake-like or serpiginous. When you look at that, you might say, gosh, that looks unusual. I've got crusted papules. I think it might be pyoderma, but this arrangement of the lesions is so unusual. I'm concerned that there's something else. So your level of confidence is not very high. That's when you should go ahead and actually do the cytology and prove to yourself that there really is a bacterial infection. Why did we use clindamycin with Sasha? Well, there'd been a poor response to prior cephalosporins. Admittedly, we had a poor history in terms of what the dose was, and the owner said that the duration of each of those two courses of cephalexin and ceftriaxone has been very short. But still, I thought it was worth changing the antibiotic to clindamycin. And if we look at what are our choices for first-tier empiric antibiotics, mostly, of course, people are going to use cephalosporins or beta-lactams, and we've spoken about those now, Convenia, Simpracef, Cephalexin. However, there are other antibiotics which are quite appropriate to use as first-tier empiric choices. And in two recent publications, on the left-hand side here in Veterinary Dermatology, guidelines that were published in 2014, and on the right-hand side here in the journal Veterinary Record, guidelines that were published in 2013. And essentially, those guidelines indicate that appropriate antibiotics for empiric use in the treatment of superficial pyoderma include beta-lactams, like cephalexin, ceftriaxone, cefobacin, and also amoxicillin clavulanic acid, as well as the lincosamide, lincomycin, and clindamycin, and potentiated sulfurs. So in this instance, where there'd been some question mark about response to cephalexin and ceftriaxone, I elected to use clindamycin. It was a successful treatment for Sasha. Okay. Our next case is Misty. Misty is a 7-year-old mixed breed dog. She has a long history of treatment for greasy yeast infections. And she's had a variety of systemic antifungal agents that include ketoconazole, itraconazole, and in fact even griseofulvin. Now, ketoconazole and itraconazole are really good drugs to be used systemically for the treatment of malassezia or yeast infections. Griseofulvin is a kind of old-school antifungal that we used to use with some success for dermatophytes, but we don't have any information on its efficacy in the treatment of yeast infections. So this was used in this dog on one occasion, and I would advocate that you don't try griseofulvin. It's not a very good drug for yeast infections. The dog had also had a variety of topicals, all of which have been shown to have efficacy and some effect against yeast or malassezia infections. And they included chlorhexidine, miconazole, ketoconazole, and selenium sulfide. Initially, years ago, there'd been really good temporary response. This dog would do very well, but then these greasy yeast skin infections would tend to come back. But more recently, the response hadn't been quite so good. On physical examination, there was this greasy seborrhea affecting most severely the ventral neck. And as we look at this close-up over here, we can see that there's alopecia, there's erythema, the skin is lichenified, which means that it's thickened, and it's really greasy and odoriferous. And I think all of you have probably seen these dogs with yeast infections, and you can smell that dog, and this is what they look like. There's no papules, pustules, and crusts here like we typically see with bacterial infections. This would be a classic yeast infection if ever there was one. The dog was also affected on its lateral trunk area and the groin area, as well as around the claw folds here. So diagnostically, do we really need to do cytology on Misty? Can't we all smell and feel this dog and say this has to be a yeast infection? Can't we go ahead and dispense antifungal agents? Well, I'm going to strongly urge you to do cytology whenever you think you have a yeast infection. Because with Misty, we did cytology from the neck, the groin, and the claw folds. And we found 4+ coccoid organisms. So you can see there are large numbers of diplococci here, very few inflammatory cells, although some of them were to be seen on some of the fields. And these are just keratinocytes here. And interestingly, there's absolutely no yeast infection whatsoever. This dog has what we call bacterial overgrowth syndrome. And it looks exactly like, and it feels like, and it smells like yeast overgrowth syndrome. Lo and behold, when you do cytology, there's lots of bacteria. Most dogs that look like Misty do have yeast infections. But you have to be really careful because some of them, it's really a bacterial infection. The treatment for Misty was cefalexin, 250 milligrams twice daily. The owner called within 24 hours and said the dog's vomiting. As a result, we gave her an injection at the labeled dose of 8 mg per kg subcutaneously of Convenia, sulfovicin. And this was one of very few cases that had a bacterial infection where we used benzoyl peroxide shampoo to be used once weekly if the owner could manage it. So I'd like to comment on some aspects of Misty's diagnosis and treatment. Why do we use benzoyl peroxide in this dog? I've already commented that the best evidence exists for chlorhexidine in the resolution of bacterial infections of the skin. Well, benzoyl peroxide actually has some pretty good antimicrobial activity. Not quite as good as chlorhexidine, but it has good antibacterial activity. Its advantage in this situation is that it's a great degreaser as well. And this dog has greasy seborrhea. So we want to remove the grease as much as possible, create an environment that's unfavorable for this overgrowth of the bacteria, and not just relying on our systemic antibiotics to resolve the infection, but also creating this environment which wouldn't allow continued overgrowth of bacteria. I want to point out, though, that once the greasy seborrhea is resolved, maybe after 2 or 3 weeks of treatment for Misty, we don't want to continue using benzoyl peroxide. Once you've got rid of the greasy seborrhea and you've resolved the bacterial infection, for maintenance long-term treatment, convert back to a chlorhexidine shampoo. Because once you've stabilized back to relatively normal skin, we don't want to be stripping out the lipids using benzoyl peroxide, and because we know that lipid barrier defects are so important and so much part of the development of allergic disease in dogs. So it's really, whenever you use benzoyl peroxide, it's temporarily whilst you have greasy seborrhea and no longer than that. Cefalexin and Convenia. You know, shame on us that we did not ask this owner to share her experience about pilling. And the reason is we honestly just didn't ask her. It turned out that the dog started to vomit with the cefalexin, so that Misty got an injection of Convenia after 24 hours. And when that happened, the owner told us that she really disliked getting the greasy seborrhea on her hands and her clothing twice daily when she had to pull the dog. And you know what it's like when you handle these dogs. You can wash your hands. But when you have lunch or when you have dinner later that day, you can still smell these dogs on their hands, even if you've washed your hands 5 or 6 times. So you can appreciate how this owner felt, that having to control this dog and get her hands all over the dog whilst it had this greasy seborrhea twice a day to give oral antibiotics. She was just delighted not to have to pull her dog. We should have really offered her that option of Convenia right from the get-go. Okay. Our second last case here is Duke. He has a history, an 8-month-old dog, Labrador Retriever, young dog, chocolate lab, and he has a really short history of skin disease. Really just a 4-week history of a rash on the abdomen, which the owner didn't really worry too much about. Saw a couple of things. Essentially, only saw the rash after about 2 or 3 weeks ago, but noticed the dog was becoming slightly pruritic about 4 weeks ago. Started to look a little more closely, but the reason why the dog was presented now was because in the last few days, that pruritus had grown from maybe a 2 out of 10 to a 5 out of 10. When we examined the dog, it really was very mild disease. If you've got to look kind of closely here, and I know it's difficult to see, But there was maybe a rare pustule. There's a pustule there. And there actually are a few papules in this dog. Maybe I'm pointing out a few. This could be another pustule. But this is the only area of the skin that's affected here, on the poorly haired area of the ventral abdomen and groin, and there really are very few lesions. So we did a deep scraping. This is a young dog that has a papular dermatitis. Of course, you'd be concerned about Demodex, and it's mandatory that you do a deep skin scraping. That was negative. So given that we have a papular dermatitis that's not associated with pneumococcosis, likelihood is very high that this is a staph infection. And what's happening here with Duke is that he has a little pruritus over the last 3 to 4 weeks. It's the early stages of what is probably going to become allergic dermatitis, either atopic dermatitis or food allergy. And it's very early in his disease. And as a result of that, he's developing his first bout of superficial staph pyoderma. It's pretty mild at this point. The treatment for Duke, chlorhexidine spray, applied once a day for 7 to 10 days. This is a 4% chlorhexidine spray, Tris-Chlor-4. There are a variety of other products which might have anything from a 2 or 3 or 4% of chlorhexidine. In fact, if you're using chlorhexidine just to treat staph skin infections, you probably only need a 1 or 2% concentration. Most of the products available in the U.S. are 2, 3, or 4%. And the reason why that's the case is because those are designed to not only kill bacteria, which they'll do very effectively, but if you want to kill yeast, and if there's a mixed infection with staph bacteria as well as Malassezia yeast, that's when you need probably a 3 or 4% concentration. So most of the products that are available are those higher concentrations, although typically known for staph infections, you only need 1 or 2% concentration. And because that's relatively easy to do, most owners could say, yeah, I can spray the ventral abdomen of my dog every day for the next 10 days. That's all that was done with this dog. So I really want you, every time you make the diagnosis of a superficial staph pyoderma, to ask about that specific case and ask yourself, is there a possibility that I could treat this infection with topicals alone? Mostly you're probably going to have to use a systemic antibiotic. But if the condition is localized, if it's an area where there's very little hair, and if the owner is willing and able to spray or bathe or wipe the area regularly, like every day or every second day for maybe 10 days or 2 weeks, if you can meet all of those criteria, you may well get away with just a topical. Of course, the majority of dogs with superficial staph pyoderma, it's more generalized, they have more severe disease, it affects areas that have hair covering the lesions, and it becomes very difficult just to use topicals, and you'll probably need a systemic. But this is an important thing to ask. Okay, the final case I really want to discuss here is Tuba. Tuba is a 7-year-old Dachshund, and she has a fairly long history of about 4 years, multiple bouts of pyoderma since she was about 3 years of age. They were intermittent initially, but they become more frequent recently. And she responds fairly well to a variety of antibiotics that are being used. The owner reports using antibiotics, reasonably to pretty compliant most times, and they report that generally the lesions get a whole lot better when they use antibiotics, but it keeps coming back, and it's been more frequent in the recent past. The current infection and the current lesions, there's been no improvement, and this is after 2 weeks of cephalexin at a dose that was acceptable, above 20 mg per kg, and twice a day. And these owners are pretty compliant, and although they may have missed a couple of doses, they felt that they had administered the vast majority of the doses that were needed. And that had been followed actually by 2 weeks of amoxicillin clavulanic acid, for us in the U.S., Clavamox. And once again, they'd been pretty compliant. There was a good dose that had been administered. So with a failure to respond to 2 very good antibiotics that we could typically use empirically to treat staph pyoderma. Some physical examination of Tuba. There are these multifocal areas on the trunk of alopecia. This is a little different to Sasha, that sharp hair that we saw earlier. Because when you look closely at Sasha, remember I said there were no papules, there were no pustules, there were no crusts. This dog actually on physical examination does have some lesions which are more suggestive of pyoderma. So when you look really closely here on the ventral abdomen, you'll see these areas. There's epidermal collarettes, as you can see in the margin of the lesion is the raised edge of the stratum corneum, and there's this area of depigmentation and sort of erythema. So these areas of epidermal collarettes and depigmented lesions on the ventral trunk, and this is what we saw that were consistent with the lesions that were seen on the rest of the trunk as well. Skin cytology under the crust and from the epidermal collarette on tuber showed 2+ coccoid organisms with some inflammatory cells like neutrophils, and as well there were some intracellular coccoid organisms. Probably difficult to appreciate the intracellular capacity here, but this what we have here is a neutrophil, and you can't see the outline of the cytoplasm so well, but these organisms here are being gobbled up by this neutrophil. And of course there's bundles of bacteria outside extracellular as well. There's clearly an infection here. We have large numbers of bacteria, and we have inflammatory cells, and I don't think anybody would argue that this is consistent with a superficial staph infection. This dog, we performed a bacterial culture. Why did we do that? We've talked about 6 or 7 cases previously where we went ahead and just dispensed a variety of different antibiotics, mostly beta-lactams, and one of them was clindamycin. But in this instance, this dog needed a bacterial culture. So why the bacterial culture? Well, there'd been a poor response to 2 beta-lactams. They'd been administered for roughly 2 weeks at appropriate doses with pretty good compliance. The thing that you've got to understand is that when staph is resistant, it's multi-drug resistant. So failure to respond to cephalexin should prompt one to culture, because I suggest that you do not then say, well, I've got some other very good antibiotic that I use empirically, like clavamox, amoxicillin clavulanic acid, that is, which is what happened here. The dog failed to respond to cephalexin, and then they empirically chose to dispense and use amoxicillin clavulanic acid. I think it's really important that you understand that when staph fails to respond to appropriate doses and appropriate duration of beta-lactams especially, that it's time to do a culture, because resistance to one beta-lactam almost always implies resistance to a variety of beta-lactams as well as other antibiotics. So the question that you should really know is, when is it important that I should suspect that there's a resistant staph infection and that I should culture patients? Because none of us want to culture patients when it's just a susceptible staph causing the disease, and we're going to spend a lot of money on a result that tells us that we have staph susceptible to every antibiotic. There's strong indications in certain patients that you should culture. And here are the indications that actually come from those ISCAID guidelines that were published in veterinary dermatology last year that I mentioned previously. So if there's less than 50% improvement after 2 weeks of an antibiotic, then you should definitely culture the lesions. The question that you might ask yourself is, if you dispensed an oral antibiotic, the first thing you'd want to determine is, has there been compliance and adherence with administration of oral antibiotics? If you believe there has, and we did believe that with tuber, or if convenient, an injectable antibiotic was dispensed, for the vast majority of dogs that have staph infections, they should be 80 to 90 to 100% better after 2 weeks with an antibiotic. So less than 50% improvement would strongly suggest that there's a resistant infection and you should culture it. Second, if you evaluate a dog after 2 weeks of an antibiotic and there's been improvement, and it might be 60 or 70% improved, but what you're seeing is new lesions like pustules, which honestly have only been there then for a few hours, maybe half a day or a day. That would imply that there's probably resistant bacteria leading to new lesions. And even though there's maybe been a 60 or 70% improvement in the lesions that were there originally, the new lesions suggest that there's resistant infection leading to a resistant staph pyoderma, which you should culture. And for superficial pyoderma, failure to totally resolve the infection after 6 weeks of antibiotics would suggest that there's a resistant infection. So those are the 3 main indications when you should perform bacterial culture according to the guidelines. So for tuber, we cultured what we found, not surprisingly, given the failure to respond to cephalexin and ceftriaxone. We found a methicillin-resistant staph pseudointermediate that wasn't just resistant to the beta-lactams, but was also resistant to the FQs, which are the fluoroquinolones, all of the ones that were tested, that is, resistant to potentiated sulfurs, and was also resistant to doxycycline, which would mean that isolate was also resistant to tetracycline, by the way. And when we looked at the susceptibility profile, the only antimicrobials to which this methicillin-resistant staph was susceptible were the aminoglycosides and chloramphenicol. And given that aminoglycosides are only available in injectable form, and there's significant nephrotoxic and odorous toxic side effects for dogs that are administered aminoglycosides, we went with chloramphenicol. It was dispensed at 40 to 50 milligrams per kilogram 3 times a day. Not an easy drug to administer because it's 3 times a day. And there's some issues you need to be concerned about, and I impress upon you to look at the potential side effects of chloramphenicol, and also to make sure that owners wear gloves because there's an aplastic anemia that can occur in some owners when they're exposed to chloramphenicol. This dog was also treated with a dilute solution of sodium hypochlorite, which is bleach, and was a 0.2% concentration to be applied as a rinse twice weekly. You have to make that rinse up fresh every time because it degrades very rapidly. And that's a 0.2% concentration, which has been shown to be effective for some staph skin infections. So that's the 6 or 7 cases. And at this time, before I kind of wrap it up and give you the high points and what I think are the most important take-home messages that I want you to think about when you go back to your practices tomorrow, I want to just see if there have been any questions that have come through that I think might be of value that I share some answers with you. Matthew, do you have any questions?
We do, absolutely. Thank you so much. And before we jump into those questions, there's a couple of things to remind our audience of. First of all, today's session is being recorded, and a replay of this will be made available to you within 5 business days. So keep an eye on your inbox for a couple of those. Also, if you have questions that you haven't already submitted, please feel free to do so. Any questions we're not able to get, we will certainly share with the team, so they'll have your perspective there. So Dr. Hillier, I'm going to jump into the first question that I have here, and it has to do with staph pyoderma. We had someone to write in and ask, how long should I treat superficial staph pyoderma?
Thanks. That's a really great question, and I didn't address that in any of the cases there. I think you might have seen that what I do is I will treat for 2 weeks and then ask the owners to come back for a recheck. And if there's been compliance, or certainly if you've used Convenia, or if there's been good compliance with orals, I think you'll find that the vast majority of dogs with everyday superficial staph pyoderma are significantly better, probably 80 to 90 to 95% better, if not resolved after 2 weeks. And I like to see them after 2 weeks then, because if that's where we're at, I probably don't need any further antibiotics, certainly not if it's resolved. And if there's just a few mild residual lesions, a couple of crusts, a rare papule, you probably don't need any further systemic antibiotics. I'll just go with my chlorhexidine spray or using the chlorhexidine shampoo on those residual lesions. The point I want to make here is that I'm trying to reduce the duration of systemic antibiotics that are used. I know I have said many times in the past, and I advocated that we should treat to a week beyond resolution. The fact is that we don't have any references that tell us that that's important. I think that if we treat to resolution, and initially with systemics and maybe the final few lesions, residual lesions, just with topicals, that most of the time that's all that's necessary. And if we can reduce the duration of antibiotic therapy to some extent, then I think we reduce the possible resistance that we might see, an emergence of resistance in some dogs. So I think that's the benefit. So, the answer is not easy. We don't know how long we should treat. My suggestion to you is get them back after 2 weeks and see where you're at. If it's less than 50% improvement, you might have a resistant infection and need to culture it. But if the dog's doing really terrifically, maybe you don't need any further antibiotics, and just some topical is all that's necessary at that point in time. Matthew, are there any other questions that are coming? Because I think we've still got a bit of time that I'm willing to answer some.
There certainly are. So the next one, we had several people write in to ask about what's the best way to culture a dog with a superficial pyoderma. So thoughts on techniques there?
Sure. Another great question. We didn't get to talk about how to culture. We mentioned when it's important. So that is the first thing I really want you to take home, is to understand when it is important for you to culture. What should you culture? If you look at all the literature and the evidence that we have, the likelihood of growing staph is really, really good if we culture pustules. In fact, just give me a second here, and I'm going to go back to moose, because moose has pustules. And I think I can find moose here. Yeah, we see it here. Remember moose, our very first dog? So he has pustules, and here's a pustule. And the way to culture the pustule is actually to clip the hair here, not with all the surrounding hair. You want to clip away so that you clearly expose the pustule. Don't use electric clippers, because you'll probably damage the pustule and it'll be gone. Just use scissors, okay, and clip the hair. Once you've exposed the pustule, I take a narrow gauge needle, like a 25 or a 26 gauge needle, and I'll lance that pustule. And a little bit of blood, sometimes the pus, but it might be hemopurulent material, will come out of that pustule. And all I do is I'll touch that, my culturette, my sterile culturette, to the material that exudes out of the pustule which I've just lanced. And that's what's going to be submitted. The studies that we've seen show us that 98% of the time that we culture pustules, we actually will get staph growth. And that's better than any other study. For example, we have a study that cultured epidermal collarettes. And when they cultured epidermal collarettes, only 82% of the time did staph growth. So I prefer to spend 30 or 40 seconds really looking carefully. And by the way, that's what happens here with moose. You have to look in between the hair in this hair area to really find the pustules. But it's worth spending the time looking for pustules, because the probability of getting a positive growth is better than with collarette. In fact, if I don't have pustules, if I truly can't find any, what I'm going to look for is a fairly fresh crust that is adherent, and I'll remove that crust. And if there's a little bit of moist material, a little bit of pus, a little erosive surface underneath that crust, then I'll culture that. And I think the probability is also somewhere in the 95 to 98% range that you'll get the staph isolate out of the area underneath the crust. I'm looking at this full time. So is there another question? I think I'll take one more, Matthew, if there's anything there.
Yes, we do have one more, so we'll go ahead and pose this question. I know you have some closing thoughts for us as well. But we had someone to write in that they had heard that the third generation cephalosporins, like Candida, are a risk factor for resistant bacteria infections. Is this something that's true, and should they be first-line antibiotics? So what are your thoughts on that?
Yeah, that's also another excellent question. You guys are full of great questions here, and I wish we could have 2 hours, because I bet there are a whole bunch of questions, and I'll try to answer some of those or many of those if I can, with a compilation of answers to address the other things that come through. But clearly there are a lot of questions. So, do the third generation cephalosporins like Convenia, are they significant risk factors for the emergence of these resistant infections? And some people of the opinion that maybe they should not be first-line antibiotics. My answer to that is, first of all, we must understand that whenever we use antibiotics, be it a short-acting, amoxicillin for a single treatment, or we dispense 3 months worth of a fluoroquinolone for a deep bacterial infection, it doesn't matter. If we use systemic antibiotics, we always put that patient at risk for the emergence and selection for resistant infections. And we kind of forget about that sometimes, but it's absolutely true. The resistant infections that people are concerned about are primarily methicillin-resistant staph student intermediates, and also drug-resistant E. coli in the feces. As far as I'm concerned, and when I hear people talk about this, those are the 2 things that specifically concern people. So firstly, I've evaluated the literature on both of those, and in methicillin-resistant staph infections, there are about 6 or 7 articles that have looked at the risk factors. And there are 2 things that are risk factors for the emergence of methicillin-resistant staph in dogs. Number 1 is visiting veterinary hospitals. That makes sense, because we have these methicillin-resistant staph skin infections. They're on the surface of the skin. Dogs go into veterinary hospitals. They rub up against the furniture. They lie on the ground in the reception area. They get handled. people will touch them with their hands. They don't wash their hands immediately. They transfer organisms to other dogs. So I think most people will realize that visiting a veterinary facility is clearly a risk factor for a dog developing a methicillin-resistant staph infection. In fact, 4 studies have shown that. Administration of antibiotics has also been shown in 4 studies to be a risk factor for methicillin-resistant staph infection in dogs. But all of those studies, none of them showed that beta-lactam antibiotic use or cephalosporins for that matter, or any particular cephalosporin, be it first or third generation, doesn't matter. None of them showed them to specifically be a risk factor for methicillin-resistant staph. The only specific antibiotic class or antibiotic that was a risk factor was in one study where they showed that the use of clindamycin prior to the methicillin-resistant staph had been a risk factor for the emergence of those resistant infections. So I think the message is that we have to understand that regardless of whether you use a first-generation cephalosporin, a third-generation, clindamycin, as far as I'm concerned, any of the first-choice empiric antibiotics that you can use for staph, all of them put the patient at risk for developing these potential risk for developing these infections. And the other thing is visiting veterinary hospitals. And very quickly, the other concern from some people is that when you administer antibiotics, dogs are likely to shed drug-resistant E. coli in their feces. And in fact, that's really been looked at quite carefully in a number of studies. And there are 4 antibiotics where people have looked at, do we get increased drug-resistant E. coli being shed in the feces of dogs that have been administered antibiotics? And the 4 antibiotics that have been evaluated are amoxicillin, cephalexin, enrofloxacin, and cefovecin, which is Convenia. And the fact is that with every single one of those antibiotics, from amoxicillin to cephalexin to enrofloxacin and cefovecin, in all cases, dogs have an increased shedding of drug-resistant E. coli whilst they're being administered the antibiotic. The good news is that it reverts back to normal susceptibility profile of the E. coli once you discontinue the antibiotic. So we do have to be concerned. Those studies, all of those studies, show us that we do need to be concerned. Those things do happen. But the way I evaluate it is I say, if you're concerned that the third-generation cephalosporin like Convenia or cefovecin actually increases that risk, then you can't use cephalexin. You can't use amoxicillin clavulanic acid. You can't use enrofloxacin. You can't use anything systemically because all of them increase the risk. So we have to accept that risk. Thankfully, it's transient and temporary. But I don't think that the indications are, when we look at everything, that antibiotic use in general increases the risk for resistant infections. And at this point in time, there's no indication that third-generation cephalosporins increase that risk any more than any other class or specific antibiotic. So yeah, time's running on here and we're getting close to the hour, and I just really do want to wrap up here. Thanks for all the other questions, and I do hope that I can disseminate something that addresses many of the questions that you have. So lessons learned from our presentation tonight. When to perform cytology. Basically, it's pretty easy. If you have any doubt in your mind that what you're looking at is staph pyoderma, as soon as you have a question, you're not 100% confident, please do cytology and confirm that there really is a cockpit infection. Know when to suspect a resistant infection and when you should perform a culture, and we discussed that. And communicate with owners to understand their needs and possible challenges in treating their pet. Not only concerning topicals, because some people just can't do the topical medications that we'd like them to do, but also ask them to share with you their experience of when they last administered an oral and how easy or difficult that was and the challenges for them. With regards to topical therapy, what did we learn? Can it be done alone? Maybe that's all that's needed. Secondly, chlorhexidine is clearly the best choice for most bacterial skin infections. And consider what the owner can and will do. Then you do things like dispensing sprays or leave-on conditioners, which are much easier for people to do and sustainable, rather than shampoos, which are onerous and difficult and dogs don't dry off from that. So you might want to think about using some sprays and residual leave-on conditioners a little more frequently than what you've been doing in the past. And finally, here in terms of systemic antibiotics, assess the owner's ability to administer oral antibiotics. Find out who can, who wants to, and who will complete a full course of oral antibiotics. If we want to resolve the bacterial infection, we have to have compliance with antimicrobial therapy. We need or in most cases, at least 2 weeks worth of treatment. And if they're not going to comply with that, they're going to stop prematurely, if they're going to miss significant doses when it's all antibiotics, there are some other options that may be better, that will more likely lead to resolution of the infection. Always offer what you believe will be the best medicine for the particular patient. Assess the patient, assess the owner, and treat the patient and not the disease. It's important. It's not just one treatment that we use for superficial staph pyoderma. What is it about this patient and what is it about this owner that makes this particular treatment the best thing, whereas I'm going to see another dog in 20 minutes' time for the same disease, and I might choose some different treatments. And hopefully talking about these 6 or 7 patients where we've used some different things has given you some insight into what you should consider as the best treatment for individual patients in certain circumstances. And with that, I'm going to leave it at that. Thank you for your attention. I hope you have a wonderful morning, afternoon, evening, whatever it is, and we'll speak again sometime in the future. Good night.
Dr. Hillier, thank you so much for your time and for your expertise on today's session. We'd also like to thank Zoetis again for its sponsorship of today's session. Thank you for joining us for this Vetfolio webinar. We hope that you've enjoyed today's broadcast. We look forward to supporting you on a future session. Have a great day.